So welcome everyone, and this week we have this tricky case of the month meeting, and we have four interesting cases. We have Dr. John Mukhopadhyay from Patna and Dr. P.N. Gupta from Chandigarh, who both are extensively experienced in this field, and we thought that their presence would throw more light on these cases. We also have Anil Agrawalji, Ranjit Desmukh, and many other senior colleagues. We would take their help. So I would invite Sheenam to start presenting cases. And we have current fellows, Dr. Sheenam Bansal, she is from Amritsar, and Dr. Meet Jain, he is from Mumbai. So they would present one by one. Sheenam,
yes,
please share your screen, yeah?
Yes, sir.
Please start.
Good evening, everyone. I'm going to present this case. 3 years old boy presented to us from a remote area of Rajasthan with difficulty in standing and buckling of extremities when asked to do spotted walking. We can see he is not able to bear weight on both lower limbs. He had no history of fever, trauma, or bowel or bladder incontinence. There was no history of night pains. He had adequate milk intake.
So before we move ahead, Sheenam, Gaurav, did you look at the video of this child?
Yes, sir.
Dr. Gaurav?
Yes, sir.
And this is the history. What would come to your mind, when you see a child from your consulting chair, when a father tries to put the child down and he is not taking weight, he is irritable, and this is the history, what thing would come to your mind?
She told there is something in the tibia also.
Can you speak little louder, Gaurav? We are not able to.
Yeah, I think she also said that there was something on the X-ray finding also. She told something on the tibia, upper part of tibia, which she told her.
Gaurav, just we are coming to X-rays little later, but these are the finding. And this, Sheenam, can you play that video again, please? Go back to a slide. Yeah. And Dr. Anil Agrawal, this is father is saying this is happening for about a month now. And for 1 week, child has stopped walking or standing, Yeah, show the history, Sheenam, and Gaurav, what do you think this can be?
So I would like to, So I would like to rule out transient synovitis, one, where the child is not bearing weight. And is there anything neurological which is?
Right. So neurologic is one differential. Chinmay is saying proximal muscle weakness, unsteady gait, or any upper motor neuron lesion. That's right. Let's see what we found on clinical examination. Then we'll take opinion from John and PNG. Sheenam?
Yes, sir. He was irritable while we attempt to make him stand. Reflexes were normal. There were normal sensations. Power could not be elicited because he was very irritable and painful.
So, John, what we should think when we see such presentation? What things we should keep in mind?
Yeah, so the possibility that the child's having, one is some weakness in the muscles. That's, of course, has already been mentioned, that he's not able to bear weight, or he's having pain when he's trying to do that. So those are the two things that you need to look at. And pain could be due to various things. It could be related to infection, trauma, some fracture, or anything like that, which you've not or could be metabolic in cause because of some stress fracture type of thing. So we need to look at that and look at weakness in the lower limbs for whatever reason, starting from the spine, muscle paralysis, etc.
So father was very clear that he did not have any history of fall. That's one.
Okay.
And his sensations were fine, like he could feel, and he was retracting a little bit when we were touching it. And the child was dairy intake being inquired, and they said they were farmers, so, and they had cows, and so dairy was not a problem. So these are the things. And then some more suggestion. How are the joints? So joints were okay. When child was not bearing weight, there was no problem with the joint. Muscular dystrophy, that's, so we are talking in terms of a neuromuscular issue or some trauma. Yes, Dr. Gupta, what do you think? What it can be?
My feeling is that seeing the history and the examination, the muscle dystrophies, they don't present with such a dramatic
too early.
history.
Yeah, it's too early.
Too
yeah.
early.
It's too early. Second thing, it's too early. And even if we think of some rare conditions, they don't present in a period of 1 month.
Yeah.
So I would narrow down to, if it is painful, some sort of viral myositis or something from the spinal cord, like
Right. Or some infective
Infection.
viral infections of the, I mean,
Yeah.
like this autoimmune viral, like transverse myelitis, or I mean,
Yeah.
something of that sort, or Landry-Guillain-Barré syndrome, or something of that sort.
Right. So Bansi says, I have seen a DMD in a 5 years old. That's right. But earlier on, they have this Govas sign positive. When they are not able to stand, that is pretty late. Yeah, Sheenam, move ahead and show what is further.
Oh, yes, sir.
So GBS, Gaurav is thinking as well. We also thought the same. Yeah, Sheenam.
Again, not so common at this age, is it? Guillain-Barré's?
GBS we see on and off. We see some weakness and acute flaccid paralysis sort of picture. Now this patient is coming from remote Rajasthan, so rarely we see acute flaccid paralysis also.
Polio, you mean?
Polio, that is a rarity. We refer them right away to pediatrician. But these are the differentials which we thought, as you all show the list of differentials we thought, Sheenam.
Yes, sir. Now, what may be the differential diagnosis? It may be Guillain-Barré syndrome, as sir said. It may be acute neuritis or myelopathy, acute neuronal regression disease, spinal cord compression disorder, or it may be vitamin D deficiency associated myopathy.
So as my wife is endo, no, we see sometimes very severe rickets, and they sometimes present with convulsion because of hypocalcemia. And sometimes those patients would present this way. So that was also one of the differentials. So the first thing we did was X-ray. Can you show, Sheenam, what is further?
This was the X-ray showing both lower limbs.
So Bansi, how would you, do you find anything abnormal on this X-ray? Or Amitosh? Or Chinmay, anyone can take this X-ray. I mean, this does not look very typical of rickets though.
Certainly not. Yeah.
Sorry? So Dr. Anil Agrawal says this can be scurvy. So scurvy may we see this sclerotic margin along the epiphysis, Wimberg's line or something. Can you show the close-up view, Sheenam? Chinmay says that distal femur looks sclerotic. Anilji, why do you think it is scurvy? What findings you think?
Sir, these radiographs are typical of scurvy.
What we see, can you guide our fellows?
This is not exactly typical, sir. The features of a classical scurvy are you will find hollowed epiphysis with osteopenia. This one is the classical sign, the dense physis, the physeal plate is the dense. Then there is the lucency above it. After some time, if you give vitamin C, you will see a hematoma collection over here on the margins, which is not still present. And if you do lateral view, you can see other features as well. If this is AP view, in lateral view, you will have other features. And if you suspect it, then you have to look for other features like petechiae, gums, and other supportive signs, which will help in confirming the diagnosis of scurvy.
So this child did not have any petechiae all over the body, gums
Yeah,
were
it's
not
not necessary. It's
Yeah, just,
scurvy has got a whole spectrum.
I'm just telling you the clinical synopsis.
Maulin,
Yes.
do you think this there's a sort of increased shadow for the joint line? Is there some effusion or something in the joint? Because if you follow this,
Yeah, I saw that shadow, but that might be just the cartilage shadow, and the overall knee joint was not looking extremely swollen.
was it swollen at all?
Yeah, there was a bit of swelling, but not too much.
Not to get excited about.
Do you think there is any periosteal reaction? I didn't find it any.
I can't see any periosteal reaction to be honest.
Yeah. Right. So, Bansi says non-identical changes.
Maulin,
Yes, PNG.
what I observed on the full length.
Go back to full length X-ray, Sheenam.
There's a little obliquity in the pelvis. Looks like
Obliquity in what?
pelvis.
Okay.
You see, the pelvis is oblique.
Right. But now I can tell you that spine was straight and the child was irritable in taking X-ray, was moving. So there is no structural obliquity.
Okay, positional, or else there is something in the hip or spine which is
I agree with you that left lower limb looks little higher, but this is just a child and there was no structural deformity.
Okay.
Fine. Sheenam, further show what investigations we did. Go ahead. So lab is showing bit of low hemoglobin and a bit of lymphocytosis with normal count. Yeah. Move further, Sheenam, and tell what.
CRP was also normal. Vitamin D and metabolic profile was normal. Patient was referred to a neurologist. Neurologist denied any neurological condition, and nerve conduction study was also showing there was no evidence of polyneuropathy.
So, John, metabolic workup is normal, infective workup is normal. Neurologist has seen the child. There is no evidence of polyneuropathy or muscle weakness. CPK was also normal. So how to deal with this now?
So you've ruled out vitamin C deficiency, is it?
No, we have not. How would you check vitamin C deficiency?
Or giving him vitamin C and seeing if it
So
helps.
we have not done it yet, but based on this, any other than vitamin C, should we think anything else? Dr. Anil Agrawal says a trial of vitamin C.
Yeah, that's exactly what I was saying.
That's why I'm attending you. But anyway, so
what about so there's no evidence of any trauma anyway?
There is no history of trauma. Spine X-ray is normal.
No effusion in the joints.
No effusion. Yeah.
Okay. Then that's the only thing I can.
Yeah. So then now the journal clubs help. Helps, and the fellows. They read a lot. So Sheenam brought this into to my consideration. That sir, I read a paper on present day scurvy, and they have mentioned the children present with such situation.
Yeah.
So Sheenam, show what you have done literature search. Show, yeah.
This was published in Journal of Pediatric Orthopedics in 2021. 9 patients were studied and 6 patients were presented with refusal to bear weight, like in our case.
Yeah.
And 3 patients presented with limping and knee pain.
Yeah.
Yeah. Yeah,
I
go
think-
ahead with other literature which you brought to my attention. And then these papers are showing this all signs. Sheenam, you can mention those radiologic signs for all the fellows again.
Okay, sir. Then we retrospectively check the X-ray and we see these findings. Cortical thinning was there. We can see dense band in the metaphysis and lucent band just above the dense band. And there was periosteal elevation and it may be subperiosteal hematoma. There was marginal sclerosis of epiphysis.
Yeah, so I remember them presenting a few cases from Vadias as well some years ago with
Yeah.
Alarik and all. They presented a few cases very similar, although more florid than this. This is much
Yeah.
less florid. So
But you know, this before this, I did not know that we can do any testing of ascorbic acid. And then I inquired with our pathology colleagues. And only one lab in Ahmedabad is doing ascorbic acid estimation. So I said, let us, one way is, as Dr. Anil Agrawal said, you just give the vitamin C and you will see dramatic response in a week. But I said, for academic purpose, please do this test free for us. And the lab pathologist called me back that we are not able to assess any ascorbic acid level. This patient is having significantly deficient in vitamin C. So this Anilji, because that was not neglect or mental, but these patients are from very remote area and their diet is also compromised. Probably that might be the reason of this deficiency. So Sheenam, show further how we the lab markers came.
Then vitamin C came, it was undetectable.
Yeah, and move ahead.
So it was diagnosed as post-vitamin C deficiency pseudoparalysis. And so we started vitamin C 500 milligrams 1 month. And we can see now the child can bear weight, can stand, and the X-ray also it was normal. There was no sign of scurvy now. This is a close-up view. We can see now there is no elevation of periosteum. There is no sclerosis of epiphyseal margins and no cortical thinning is there. Now the child can walk, can run also.
So as Dr. Anil Agrawal said, I inquired the father that in how many days you saw the child has improved. He said in 10 days, when we gave this medicine, in 10 days time, child was walking. So
yeah,
this vitamin C deficiency that I have seen very few cases in my academic career, and I'm sure that young fellows would benefit from this presentation. And you just give LIMC trial and they would improve. So that was an eye opener for us. Yeah, Sheenam.
So the take-home message is pediatric orthopedic surgeons should have increased awareness about the diagnosis of scurvy when consulting on a child with the inability to walk. Heightened awareness is needed to avoid unnecessary surgery, unnecessary tests and procedures, and to be able to start treatment for a potentially fatal but easily curable disease, like in our case.
Right. So Sheenam, you can stop sharing your screen, and Meet, you can start with yours. Gupta ji, any piece of comment or advice on this case?
See, basically, it's very, very uncommon actually.
Yeah.
And we really don't see scurvy in my part of the country. usually, I mean, in Chandigarh, we really don't see scurvy. Not even from people around. And I had the opportunity to see only one case, which was a very overt case with lot
Yeah.
of subperiosteal hemorrhages and even a pathological separation of the. I mean, I think there was a
That's right. But you
fracture.
know,
Fracture. I
if
think
we,
it was a fracture.
yeah,
I'll not remember offhand now. This was long time back. So
yeah,
this was actually referred from the pediatric department.
surprisingly, you know, after this case, John and Dr. Gupta, I found two cases. In one more case, this vitamin C was non-measurable. The third case just came yesterday, and their X-ray findings of this Barton's disease. You see, vitamin C and vitamin D deficiency. So the reports would come, and I'll share with all of you. So in last 1 year, I saw 3 such cases.
So maybe
I-
this is a case which is, I think, eye opener, and perhaps
Yeah.
in some of the
So-
cases with some non-specific sort
Yeah.
of symptoms like
sometimes
this, I
this,
think we should start looking for.
Yeah, I think it's important to be aware of its existence and look for it where you're not sure about. And when metabolic problems or dietary problems are rampant around the country in children, so it's nothing, but definitely something that you need to look out for, and it's definitely a good message. Yeah.
And one thing which I would like to tell young fellows that when the JPOs come, you know, just go through the titles. And then sometimes you will find out an interesting paper which you would like to go through. So these are the, you know, literature search sometimes helps. Yeah, Meet, proceed.
So, good evening, everyone. So the tricky case of the month that I'll be presenting is an unusual and neglected talar head plus a medial malleus fracture. So we have an 8-year-old male child who fell from a height of 10 feet 25 days ago and sustained an injury along the right ankle. Primarily, he was immobilized by a bone setter for 3 weeks, following which due to persistence of the swelling, he went to an orthopedic colleague and who further referred the patient to us for further management. So on examination, what we found out was that there was global swelling over the anterior and medial aspect of the right ankle. The sensations over the dorsum of the foot were intact. There was no pain on passive stretch. There was no visible clawing of the toes, and the toes were well perfused. So we got an X-ray done, and this is what we found.
So before John, I mean, you are the best person to tell us about this sort of injury. So before coming to you, I'll inquire with other pediatric colleagues that how have you seen such pattern of injury in your practice, where we can see this? Yeah, John, you can guide us about.
So basically, you can see that there's a fracture of the talus with dislocation of the subtalar joint here.
Yeah.
Okay, so, and a medial malleolar fracture as well. And there's a fracture across the body of the talus as well, and the neck. So you can see there's a coronal as well as sagittal plane fractures there. So you're going to need a CT to
find out,
more detail.
And there is a small comminuted piece also which we can see on the anterior to.
So that's from the neck. But what you're more worried about is the subtalar joint.
Right. So now this was 3 weeks, 25 days old. And this is presented to us. Yeah, Meet, move ahead. Any comment from anyone else? Yeah. So for me, it was for the first time we saw such injury pattern. Yeah.
So we went ahead and got a CT scan done, as John sir just said. And this was the 3D cuts of that CT scan.
So, John, how did you help in your previous findings, or you want some further cuts?
So can we have the 3D tends to give you an overall picture, but hides the details. So I would really like to look at the other sections.
Yeah,
If you
please,
have.
Meet, show.
So the cuts that we have, the other cuts are here. We have the sagittal and the axial cuts.
You can see the plane of the fractures kind of goes across and then back. So that's why you're seeing two planes to the fracture.
Yeah.
So you've got a sagittal as well as a coronal section injury there. And you have to probably approach this from, sorry, let's not jump the gun. Okay. So, yeah. So I think even in a child, even though it's late, this is an ankle that's going to be wrecked otherwise. So you have to try and do something.
So Dr. Kishore says that he had an opportunity to fix such one case. So Dr. Kishore is an general orthopedic trauma surgeon from Surat. How would you approach this, Dr. Kishore?
Yes, good evening, sir.
Good evening.
So I did the same case, and patient was 14 years of age. It was missed by primary orthopedic surgeon.
Mm-hmm.
And I this case 10 days later.
Okay.
10 days later after the injury.
So how would you approach this?
I opened the fracture through the anteromedial approach, and
Okay.
the medial malleolar fracture was used as osteotomy. It was a natural osteotomy, so I can see the whole talus in front of me. Then I fixed with the headless screw, Herbert screw, and the medial malleor was fixed, sparing the physis with 1 4 mm CC screw. Things become all right.
Here, like, it's a type 3 Salter-Harris fracture. So John, would you like to go through medial malleolus or you would do something else?
So I would do a dual approach for this. So you go lateral and medial. And since the medial malleolus is fractured, I would make use of that to extend my approach. But I think you have to get good visualization because you have to reduce the subtalar joint accurately and also the talus as accurately as possible. So without vision from both sides, it's going to be very difficult.
Right.
Yes, dual approach I did, but just to confirm the reduction only. I have not put anything from lateral side, just to check subtalar and the alignment of the talar.
So
I did the dual.
So other question is, John, when this comminuted fracture, how easy it is to put screws across, or that will derange the, or you should do some.
How old is the child?
Sir, he's a 10-year-old.
So you don't have, even if you put screws, you don't have to compress, okay?
Okay.
So you can use headless. What I use in these are the 3.5 locking head screws.
Yeah.
So you can bury into the cartilage, countersink without having to make a big hole in the cartilage, as opposed to the 3.5 or even the 2.7 millimeter headless screws. So they work more or less like threaded K wires, having a better hold than K wires. Okay, so the important thing is to get it reduced, hold it with wires, and then put in pins in these screws wherever you feel you can put them without disturbing the cartilage and the joint as such. So it's like working out, putting all the wires, getting everything together, and then putting your screws after that.
So temporary fixation and then definitely. Yeah, Meet, move ahead and show what was done.
Because you see there's, sorry, can you just come back to the last one?
Go back to the.
So there's also a depression here. So you need to also deal with that, okay?
Yeah.
So very often there's an articular impaction which you have to lift up and then also get that corrected.
Yeah, so yeah, we faced all those issues, and we had our one adult trauma colleague who had more understanding than me in this area. So let's show what thought process went through our mind and what we did. Yeah, me.
So as we discussed, the diagnosis that we reached was a closed comminuted fracture of the talus body with a Salter-Harris type 3 medial malleus injury with normal distal neurovascular status. So What the problems and the challenges that we faced were threefold. The first was the precarious blood supply of the talus bone. The second was that it was a 25 days old fracture, and the third was that the communicated pattern of the fracture. So just to recap the vascular anatomy of the talus, the talus is it has no muscular attachments as such. It has multiple nutrient foramina in the neck region, and the blood supply is usually is mainly from the deltoid branch of the posterior tibial and the anterior tibial artery, and there are perforating peroneal branches as well. So the questions that we had about management were there were three main questions that we had: that should we intervene or observe? The second was that if we do intervene, then what approach should we have used? And the third was that which implant gave us the best possible fixation for this type of fracture. So in this paper by Bruce Sangerson, it states that displacement as small as 2 mm, they significantly alter the contact characteristics of the subtalar joint. So this simply states that even a displacement of 2 mm is significant and needs to be fixed to avoid degenerative arthrosis in the long term. We went back and in this paper by Sermet et al., we went back to see the mechanism of the injury, and on doing a proper literature search, we realized that this type of injury had been described before, and that it was a forced extension injury at the ankle with some supination component, which the supination component led to the malleolar fracture. So now looking at the CT, what approach should we ideally use? So here there are multiple approaches to the ankle. There's the anteromedial, anterior, anterolateral, a posteromedial, and a posterolateral approach. On doing a literature search, we realized that what we needed was a clear access to the talar dome. And we found out that this paper by Laura and Lambert, which was published in 2013, it's the transligamentous approach to the talar dome. What they have described is that they have taken a 26. This study was done in cadavers, and they realized that in 26 of them, when they used this approach, they found that the percentage exposure of the talus bone was 77% as compared to the others. So with all the other 4 soft tissue approaches, they could access only 76%, whereas using this single approach, they managed to get 77% exposure. So moving on to the implant options, we referred this paper by the Journal of Foot and Ankle Surgery. This was published in the year 2020, and they said that for open reduction, whether an adult or a child, we could the use of a mini fragment plate or a headless screw could always be used. There's no problem with using either of them, and the approach that we use for the talar neck fractures is very similar to that. The principles of fixation are very similar to that for a talar body fracture. So this is the intraop image. We used a mini fragment plate set, and this is the approach that we use, the lateral transligamentous approach.
So John, here so after exposing it and aligning the fragments and making sure that the subtalar joint is well reduced, we took a plate from mandibular plate set. Yeah. And then we contoured it, and this has a provision of 2.7 locking screws, which we placed in the head. And
so we've used there's actually a tailor plate available.
Yeah.
Locking. We've used those quite often on the lateral side. On the lateral side, there is a non-articular portion where you can put a plate. We even have put plates on the medial side, but we generally prefer screws. It's important to do this on the lateral side, because otherwise when you put in screws on the medial side, you're going to compress it into varus, the talus into varus.
Right. So This was what done, and after that we went on the medial side to fix the medial malleolus.
But I would always use KYS provisionally to hold things.
Yeah, that's what we also did, and then we checked under image intensifier, and then we went on putting this plate. Yeah.
So this was the interop image that we could achieve, and we have fixed the medial malleolus by 2.7 mm screws and the talus by a mini fragment plate, from the mandibular plate side.
So you didn't do anything from the medial side.
Not anything from medial side. We just placed this plate.
So it would have made sense.
Maulin, my thing is that how could you assess the reduction of the medial aspect of the body? So there's the pre-op,
Exactly.
there seems to be some depression, and did you do that intraoperatively from the fracture area? Or
You can't do it from the lateral side. It's impossible.
yeah.
Yeah. So
this fracture area, did you actually reflect the fracture downwards and evaluated the talus, or you relied on your radiograph?
So we relied on the image intensifier, and we also saw that with this provisional fixation, the subtalar as well as ankle joint was well aligned. And then we fixed, and then we checked with the stability after fixing the medial malleolus. So in medial malleolus, we just hold with a towel clip and brought it down. There was no frank mobility. I could lower it a little bit, and then we fixed with the epiphyseal screw. And anyways, we had to kind of immobilize this child in a plaster. So we thought that this is a kind of adequate fixation. And just there's a question. John said that you should put a bone graft. John, would you put bone graft primarily in such fracture?
No, not always. It depends. If you have to support an articular cartilage which is without support, yes. But
Yeah.
what
So here the articular cartilage was fine.
Yeah.
But there was a bit depression little distal to that.
But I would like to put axial screws. So from anteromedial along so because you have a fracture line which is going across as well. Okay, so
we could have added that. I agree with
yeah.
Primarily, we were worried that it might get varus collapse.
No, once you put the plate here, then it's not going to collapse.
Yeah, that's right. And we were also worried that it took a little. I mean, to mobilize all this in place.
True, it's not easy. I mean, I agree. After 25 days, it's not easy. So,
and of course, we explained to the family that it will need. That might go for AVN, not because of operation, but because of primary injury itself. Right. Show the follow-ups.
Yes. So this was the immediate post-op X-ray, as you already seen. This was the 3-week follow-up that we got when the patient came for.
Yeah. So if you look at the lateral, the talus is slightly,
and it looks like as if it has collapsed a little bit.
Exactly. Yeah.
Let's see one more X-ray, and you can comment better. Now this is at 6 weeks follow-up. Now there is sclerosis of dome.
Yeah, going into AVN.
Yeah, but child has almost kind of
reasonable range of
motion of ankle and subtalar joint, and we allowed him to walk with a ankle foot orthosis. What would you do now if we see this talar dome sclerosis? Should we ask them to avoid weight bearing, or what to do?
So what we tend to do is to put them in a PTB orthosis.
Yeah.
So they're offloading the ankle to some extent.
Okay.
Not totally non-weight bearing, no.
So what we have prescribed an AFO, and the child is moving. AFO might not
offload it enough, yeah.
Yeah.
Maulin,
would you consider intraosseous zoledronic acid? I don't think, and I don't have any experience of injecting zoledronic intraosseous. Have you tried, John or Gupta ji?
I've tried it in the neck of femur.
Yeah.
Of femur, but not in the talus. Okay.
This child was a very.
I tried it only once in a in a femoral neck where it was earlier, but I really don't know the results.
I mean,
And here, I think the problem is likely to increase. And
yeah.
irrespective
So
of whatever you do, I think they're going to end up in a ankle arthritis eventually.
No, but I'll be surprised. I've seen a lot of these talar fractures which manage for a long time before they end up in trouble. Okay.
yeah.
Yeah, they don't. They
I
take
would,
a long time, but
a lot of these
it is very
avians also, which are
it's very
managing
very
okay
difficult
for.
to eventually salvage this ankle.
Yeah, that's okay.
Sometimes they revascularize also. So we
Yeah,
have
they
just
do. So you get the
asked that,
Hawkins sign and
yeah.
they revascularize. So
yeah. So me show the final. Now this patient is also not coming to us. This from remote place. They have neglected it for pretty long time. Meet show the follow up how he's walking. And this is
So
you can see he's from a village. This is how he's walking,
not walking too well at the moment.
and this is how he's walking with for the video. But he will come soon for the follow up, and then we'll update you how it
Sure.
goes.
Yeah, sure.
Yeah. Thank you. Yeah,
Great.
Sheenam, can you present your next case? And John, any advice, piece of advice for youngsters?
No,
like
I think so. I think most of these talar fractures today, you have to use two approaches. Okay, almost all of them now, except for the very simple undisplaced fractures, because you go medial and lateral. You often first stabilize it laterally, although you get both your reduction on both sides.
Yeah.
Because you don't want, when you put the screws on the medial side, very often it compresses it into varus. So either screws or a small plate on the lateral side, and then screws on the medial side across the neck, because usually the neck is also involved. Here it's like a neck going into the body. So for the body fractures, you have to put screws across the body usually. So they vary a lot. I think but the subtalar joint is also going to be a problem here, because that was comminuted as well and displaced for a long time. So it's a tough case, and I think you've done very well. But obviously the prognosis will be guarded.
This was a bad case to start with.
Yeah,
Dr. Kishore raised his hand. Dr. Kishore, what do you want to comment?
So transligamentous approach has a limited indication.
Right.
The paper which was shared that I have read, and they have used for osteochondral defect.
Okay.
This is used for just the posteromedial corner of the talus.
Yeah.
Here we can see through the anterolateral approach, this fracture can easily be visible. So unnecessary, we can avoid the injury to ATFL. Because once we go through the transligamentous approach, one has to repair the ATFL perfectly. Otherwise, later ankle instabilities are.
Right.
Yeah.
So we repaired, sutured those things back, but we'll be careful about this. And Dr. Nimish Patel was with me while doing so. That was his suggestion. Anyways, let Sheenam share your case. Let's start with the third one.
Yes, sir. 45 days old girl presented to us with reduced movements of the left leg for 25 days. She was born at full term by normal vaginal delivery. There was history of NICU admission on second day of life for 4 days due to neonatal sepsis. There was no history of any constitutional symptoms, any history of fever or failure to thrive. On examination, her left limb, lower limb, resting in flexed position. There was no apparent swelling. She cries on a passive extension of left knee and hip. And this is the radiograph showing lytic lesion in the metaphysis reaching up to the epiphysis.
So sometimes this happens, like the child is keeping the knee flexed, and as the child flexes the knee, the hip also get flexed. So in this child, before coming to us or before coming to diagnosis, 2 times hip ultrasound was done, and the child was treated like this. There's just This might be synovitis or something, but because the hip X-rays and hip sonographies are normal. So, Dr. Anil Agrawal, how would you deal with this case
It's a
now?
case of, yeah, it's a case of chronic osteomyelitis, involvement of both epiphysis and the metaphysis,
Right.
because the child has a neonatal infection. Right now, we have to find out whether the infection is active or not. Second thing, we have to splint the limb to prevent any secondary deformities. So if any cultures were available at the time of NICU admission, we will rely on that. I don't think that the infection is quite active right now. It's basically a sequelae. So we have to just follow up the child serially. The child is too small, 45 days only. So we have to follow the child, immobilize the child initially, followed by gradual mobilization, and keep the child under follow-up for longer periods. Probably at 3 months, we have to get the X-rays, or 3 to 5 months, 6 months, we have to get the X-rays.
But this child had significant pain. You know, when we try to extend the extremity, the child would cry a lot. So,
Maulin,
that was a issue. Yes,
Maulin.
Dr. Gupta ji.
Yeah, Maulin, my approach would be to see whether, to assess clinically. What clinically, whether the infection is active, that means if it is painful, if there is a swelling, which is like a fluctuant swelling, if you are able to appreciate clinically, or if none of them is appreciable, if the child has pain, that means there is something going on there. Some activity is going on there. So I would evaluate using ultrasound, and if that doesn't pick anything, I would not hesitate to go in for an MRI.
Right.
And of course, the lab parameters.
So
And
now the issue was this child was 45 days old, NICU admission, bit of immunocompromised, and the child has the community acquired like infection right from day 4.
Yeah.
And
what I have observed in Maulin, what I have observed, we do see such like cases quite frequently.
Yeah.
What we observe in these cases is that most of the times, by the time the patient reaches the orthopedic surgeon, but most of the cases, I'm not saying all, they already have been loaded with antibiotics, and you are really not left with any drainable abscess.
Yeah.
So then in those cases, you go in for further imaging. You go in for further imaging.
Yeah.
And evaluate whether, if there is something which is tappable or drainable. Otherwise, you have no choice but to rely on your lab parameters with total count, differential count, and CRP and ESR to decide whether to continue the antibiotics. As far as the bone destruction is concerned, if there is nothing drainable, I would just like to observe this child. And a lot of times, everything grows back into position.
The family was concerned that this child's pain is not going anywhere. I mean, the child is remaining painful. With every diaper change, child had pain. Yes, John?
Yeah, so for me, looking at this, I would go in for exploring the knee and draining it out, because many times we've found it, and even if it looks as if it's settled down, when you go in, you find a lot of sort of debris and necrotic tissue. And until you take that out, it just festers on for a long time.
So that's my approach also, because you have to drain it. You have to find out which bug it is. And they need antibiotic
specific antibiotics after that. And once you do it, they settle so rapidly, it's unbelievable. So usually, I can't say always, but yeah.
So Raman says that the hip joint also looks swollen. So we got hip ultrasound, which was normal, Raman. And Gaurav says at least USG should be
felt
tried.
that the hip looks little out of the place, but that
no. But if you look at the Shenton,
it looks fine, like a positional this thing.
So the hip
I would still like to. Yes, I agree with. I would still like to.
And we got the knee ultrasound, Gaurav, as you mentioned. So Sheenam showed that knee sonography, and they found there was a fluid collection, so that there was with internal echos, and both on the metaphysis as well as the epiphyseal side, and the joint was clear, but it was abutting to the growth plate.
Yeah.
That's what was reported, and which we can see on X-ray as well.
Yeah.
And as a Dr. Anil said, the lab parameters were also not very raised because child was immunocompromised. Yeah. Dr. Raghavendra says drainage and drilling of metaphysis should be done. So that's what we did. Sheenam, go ahead.
We did decompression and drainage via medial approach, and it came out to be MSSA. Antibiotics were given according to culture report.
So were you able to drain any abscess there or any necrotic tissue?
Yeah, yeah, there's
There was abscess in the metaphyseal side
Yeah,
and on the epiphyseal side as well. But I made a window in the. I could see that my blunt probe was going through the physis into the epiphysis.
Yeah, that is a frequent.
Yeah.
Yeah.
So that was drained. It was cleared and lavaged, and we gave IV antibiotics few days at my clinic, and then to their remote pediatrician. Child did well thereafter, actually.
Yeah.
Yeah, Sheenam, move ahead.
After 1 year and 9 months, the child presented to us with genoverum deformity of the same limb.
His mom was very, very alert, and she used to call me that, sir, one leg is going out and the other leg is straight. And the first time I said, okay, we'll see when you come in follow up. And after a few months, she said, now the one leg is going out and the other is going inside. And so I said, you send the images, and then they came to see me. And as you can see, now the left leg is going into varus. And Sheenam, show the x-rays.
And now we can see there is teething of the physis. And
so presumably, Maulin, you have warned the parents about this.
Yeah, I did tell them that now that the infection which travels through the physis might have already affected the physis. It might have already injured. Yeah. But the parents have selective hearing, and they were very happy with the, as the child was afebrile, gaining weight.
Again and again.
So, Anilji, how would you manage this this thing now?
Sir, the child is still young.
1 year, 1 year and 9 months.
Yeah, 1 year. So, would like to wait at least for a few years. See the pattern of the deformity. Sometimes they are not as aggressive as him. However, this seems to be causing deformity. I would like to intervene around age of 3 years after getting the necessary imaging.
Okay.
Post-infective physeal bar have a notorious course. They usually don't, they are not like post-traumatic because the whole of the physis is abnormal.
Right.
So in traumatic types, the rest of the physis is normal, only the affected part is abnormal. But here, because the other physis is also normal, even after if you excise the bar, the deformity will continue to reoccur. So in most of these cases, a compensatory osteotomy and a contralateral growth modulation is always required, and you have to retain that growth modulation for a longer time. So I choose an age where growth modulators can be applied easily.
Right.
That is around 2.5 to 3 years of age.
Makes sense.
So we have Thomas Palikaran here. Thomas, are you with us?
No.
Thomas? Okay. So let me inquire with Dr. PNG. Would you have the similar approach of just wait and watch for now, or you would like to do something at this point? 1.9 years old boy, girl with progressive varus. Gupta ji. Or John, you can.
Yes. So I mean, we just did one on an older child with the ankle, very similar sort of history, but it was in the distal tibia, where we did a growth plate where we took out the bar and put in some fat and things like that. And we're waiting to see what happens. I agree with what Anil said in terms of the prognosis, but I think as soon as you think is okay enough, you need to map out because it looks like a small bar at the
Yeah.
moment. And I would maximum maybe document progression because you've got one and maybe see one more to document that it is progressing for
Yeah.
3 months, not necessarily wait for a long time before doing it. Because
So
I think,
anyone else have any other or approach or comment before we move ahead?
and you would also obviously have to put a growth modulation on the
Growth modulation, yeah. So anyone, Gaurav?
I would also like to wait. at this
You
point.
would like to wait, yeah?
But I have a similar case and I'm waiting.
So how long? How long would you
How
wait?
long would you wait?
I'll just see the progression for another
Yeah.
year.
Okay.
Progressions sequentially, maybe for a year, and I'll see if it progresses, then I'll do something.
Shalin, you're at Wadia. How would you approach this? Shalin, do you have any difference of opinion, or you would agree with what Dr. John said? We have a comment. There is already.
Can I
Yes,
intervene,
yes,
Maulin?
Gupta ji. We were waiting
Maulin,
for your comment.
basically, we need to see whether the virus is coming from, looks like coming from the bar,
Yeah.
but whether it is really due to the bar or due to the previous destruction of the metaphysis. So I would image this further,
So you would image with an MRI.
MRI,
Okay.
and evaluate if it requires a growth plate surgery or not. I
So
would
the-
not wait for a very long period of time
Yeah.
before attempting a
Which is
growth
what I
plate
said.
surgery here.
Yeah. Agree. So there
And
is a one.
simultaneously a growth modulation.
Right. So there is one comment that looks like there is already shortening of couple of centimeters. Wouldn't it require a lengthening along with growth modulation in future? So yes, limb length discrepancy, Puneet, we will need to address, but currently our goal should be to correct the deformity, and if it is a bar which produces the deformity, we should try to correct it because child is young. Otherwise, but as Dr. Anil said, that post-infective bars are excisions are not as reliable as we see post-traumatic bars. Yeah, so Sheenam, move ahead and show what. So we did an MRI, and as Dr. Gupta ji said, and yeah, Sheenam, say.
Coronal fat spaced view showing 6 millimeter square size of central bar involvement, and axial physial mapping representing 8% of the total distal femoral physis.
So now, again, looking at this MRI, Gupta ji, what would you do? Would you go for bar excision? Now, can you say that this virus is from metaphysis or from bar, or we can see a clear-cut bar here?
Yeah, see, Maulin, I would say this bar is more or less central.
Okay.
You know, a bit eccentric, so it's very, very difficult at this point of time to point out whether this is really from the bar or it's
From the metaphyseal
so
destruction.
at
Yeah?
the most, I mean, this looks like to me central bar, and this can cause a sort of a volcano appearance of the growth plate, which actually you see on the radiographs also.
Yeah.
So right now it's very difficult, but this bar perhaps is doable because this is just around 8%.
Now
So I
let's
think it would be better
consider
off
that,
with
that
a-
this
with a
virus
excision.
is coming from metaphysis. Okay, that virus is coming from metaphysis, but the bar is there. Would you excise it and give a chance for child to grow normally, or you would just do growth modulation?
Maulin, can you repeat that, please?
So let's agree with you that this virus is not from the bar, from the metaphysis, but
Yeah.
we know that the central bar leads to limb length discrepancy, tethers the growth plate.
Yeah, agreed.
So should not we give a chance of gaining length? That's my question.
Yeah, agreed. I I would.
Yeah, John.
Yeah, I would, like I said, I would do that. I'm not sure how successful it would be, but I'd certainly do that and put a growth modulation.
Growth
And
modulation, yeah, I agree.
prevent,
with that.
you want to prevent progression of the deformity first, and limb length is something is not so
It can
difficult.
be dealt later. So, Gupta ji, in your experience, what amount of deformity you correct acutely, and what amount of deformity you will prefer growth modulation?
See, this particular, the cora is at the growth plate and it is a growing child. So it is easily doable by a growth modulation. I would do a growth modulation.
Yeah.
I
So
would not correct it acutely in this.
Yeah. So the
agent
current literature
because
says if the deformity is more than 30 degrees, then you should correct it. But less than 30 degrees amenable with growth modulation. So yeah, Sheenam, show the
Maulin, let me share something with you.
Yeah.
I do not know what this 30-degree thing actually means, but I'll tell you, I had a patient who had around 20 degrees of valgus.
Yeah.
Did a growth modulation and lost to follow up and ended up in about 20 or 25 degrees of varus.
Yes, yeah.
So that means the epiphysis actually moved around 40 degrees.
Okay.
So I think it all depends on the age of the child. Yes, by and large, I would take 30 degrees as a cutoff point. But the potential of the remodeling may be more than 30 degrees, provided you have sufficient growth remaining.
Right.
This is my experience in about 3 or 4 cases during COVID time, especially.
Right.
Yeah.
So Sheenam, show what we studied further and what we did for this case.
This is a paper by Langenskayol. Provided that its size doesn't exceed the half the cross section of the physis, normal growth can be restored by resecting the bridge and filling the defect with fat. This is a publication published in Journal of Pediatric Orthopedics in 2006. It discussed about arthroscopically assisted central physial bar resection. There were total of 30 patients and 32 procedures were done, in which there was poor results in 3 patients who had infective etiology out of 30. Poor results, the limb segment after resection had growth ranging from 0 to 12%. And there was 14-degree mean angulation. This paper was published in Journal of Pediatric Orthopedics in 2020. They have discussed that there were 5 patients total in the study, and 2 out of the 5 were having neonatal sepsis. There was infective pathology, and there was good results in both these 2 cases, and 1 case didn't respond and it had traumatic etiology.
So now this paper is representing our case, post neonatal sepsis central physial bar, and they treated as John, we discussed that you excise the bar, give a trial, and then do growth modulation. And so we also opted to do that, even though the child was only 21 months old. And show Sheenam the result and outcome of this child.
So we resected the bar and growth modulation was done. This is the post-op X-ray.
So we did this, we removed the metaphyseal plate, metaphyseal window, approach the bar with the help of dental burr and scoop. You should do it, put a fat there, and then you can put that cortical window back in position, and then so that it doesn't become very weak. And of course, you do growth modulation. That's what done. Yeah. Show the follow-up X-rays.
After 6 months, implant was removed.
Because the deformity got corrected, as you can see.
After 9 months of bar excision, we can see the deformity is well corrected. In fact, over-corrected. Mild valgus is there.
So I opted to wait for the the deformity go in a little bit of valgus and then to remove the plate so that if it rebounds, then it's okay. Yeah, show the further slides.
Now we can see she walks like this. These are the X-rays after 9 months of recent follow-up. We can appreciate there is mild limb length discrepancies there, but deformity is well corrected.
Yeah. Go to the comparison X-ray, Sheenam.
Yes.
So, John, now what I see is, although I have excised the central bar, there are two small bars at the periphery that might be tethering the length, and that's why the shortening is happening. But if the child does not develop any angular deformity, then at least we have saved the child from multiple deformity corrections, you know. Now we'll have, yeah, you are mute, John.
Sorry. And you know there's growth happening because otherwise it wouldn't have corrected.
Yeah,
There's
exactly.
no growth. It may be tethered to some extent, but
Yeah.
there's some growth. So hopefully the discrepancy won't be a huge amount. If there was no growth, you wouldn't get correction with your growth modulation.
That's right. Yeah, Dr. Gupta ji, your comment on this.
I'll agree with John that if the growth, if the correction has occurred, that means the bar has gone actually.
Yeah.
So this, I think this needs to be observed over a period of time. I don't think so this will reform because this is just a X-ray appearance. I mean, I would just observe the child.
So it's about 6 months. I have removed the implant and it has not gone the other way.
That's
So
good.
now we are dealing with the discrepancy, and I'll keep you updated.
I think the discrepancy needs to be observed over a
Yes,
period of time.
yes, yes, yes.
If it gets worse, then you can
Yeah.
further evaluate the patient.
Meet, can you share the last case slides? So what I learned from this is that we should try to, in young children especially, we should try to resect the bar, whether it is infective or traumatic. But if it is less than 30%, and if it is in a young child, we should always give a shot. Now, I have seen such results in 2-3 infective bar patients also. So, yeah, Meet, go ahead.
So Maulin,
Yeah.
before we start, I may have to leave in a short while, so just excuse me.
So we will quickly go through this case.
Okay,
and
sure.
yeah.
Okay.
So the next case that we have is a post.
Maulin, I'll just make a 2 minutes leave to just
Okay.
make a phone call.
Yeah.
So the next case that we have is a post-infective ulnar gap non-union. So we have a 6-year-old boy. He's a resident of London, UK. 3 months after his birth, his parents noticed swelling and redness around his left forearm. So they consulted a general surgeon in the UK, and what they did was a debridement of the forearm, wound, and along with prolonged IV antibiotics. However, the discharge persisted, and the patient at 3 years, by an orthopedic surgeon, there was iliac crest bone grafting done for the same. And now, however, the graft unfortunately got resolved. However, the discharge gradually stopped, and now at 6 years, the patient has presented to us with deformity of the left forearm. On examination, as we can see in the picture on the left side, there is a shortening of the left forearm along with an apparent cubitus varus. There is also there's a apparent cubitus varus deformity, and to see the way we can see the increased bowing of the radius, there's a prominent radial head. However, the range of motion, the range of motion was full and there was no distal neovascular deficit. So we got the X-rays done for this patient, and these are the comparative views of the left and the right forearm.
So, like before John and Gupta ji leaves, yeah, John, how would you approach this? 6 years old and no no infection in recent past for last 3 years. Nothing was done. This is X-ray.
Yeah, so there's very little of the proximal ulna there, but what we have done in a few is to convert it into a single bone forearm, is to fuse the proximal radius with the ulnar remnant and then correct the deformity as well. So that gives you much better strength. Obviously, you're not going to get a normal ulna at the end of it. So I would not get too ambitious and do something like that rather than.
Maulin,
Gupta ji, what would you do?
Yeah.
But I might wait for some time before doing it.
This is the ulna which seems non-reconstructable.
Okay.
Right.
No, but his elbow joint is on that. Sorry, I can't see that.
So I think I'll agree with John that a single bone forearm is the best choice. I've had the opportunity to do 2 cases. Best position would be a mid-prone position in this particular patient.
Right. So the elbow also, the elbow joint, the proximal ulna also doesn't, the articular surface looks little.
Yeah, that's what I'm a bit worried about. So that's how stable is the elbow?
Yeah, the elbow is stable. He could do good elbow flexion and extension. Although X-ray looks bad, the child had reasonable range of motion. So, Meet, let's go through what we did, what we thought.
So as we can see on the findings, we can see a resorbed midshaft ulna. There's increased in the radial inclination. There's a sclerotic proximal end of the ulna, and we can see a few bony islands, and there's a disrupted distal radioulnar articulation. So the problems and challenges with the case were again threefold. There was a loss of the midshaft ulna, there was a forearm shortening, and there was an increased radial inclination. So what are the options that we had? We could think of osteogenesis using Elizaro method, or we could have done bone grafting with an along with an implant,
or the single bone forearm
or the single bone forearm. Yeah. So in this paper, this was by Anil Agrawal sir, and it was published in the Journal of Hand Surgery 2020. They stated that all patients had a painless functional limb at the time of final follow-up. The average shortening was around 3.9 centimeters with a preserved elbow range of motion. However, forearm rotation, especially the pronation, was severely restricted in 2 patients. So on going to literature, we found another paper which was again published by Sandeep Patwardhan sir, reconstruction of bone defects after osteomyelitis, and it stated that what they have done is after osteomyelitis they have used a non-vascularized fibula graft in 26 patients, and this was done in the femur tibia and the other forearm bones as well. So when seeing the forearm bones, we can see that the time to union, they did achieve union in almost all the patients, and the time to union was 40.7 weeks.
And the other thing was the average defect in the forearm was 6 centimeters and not more than this. And here in this case is about 10 to 12 centimeters defect. So this was a more challenging case. Yeah, Meet, go ahead.
So the challenges in this case were that we had to do a radial bow correction. We had a small proximal ulnar segment, and the distal ulna was absolutely thinned out. So what we performed, we planned for a radial osteotomy, a lateral closing wedge osteotomy, and we performed this using the radial inclination of how much we had to correct. Then the site of the ulna, the sclerotic edges, we cleared those. We harvested a fibula graft, and then we fixed it with a nail, and along with that, for rotational stability, we kept a fixator for some time.
Yeah, so John, this is what we could achieve. I placed in diaphyseal plate to correct the radial inclination. Removed the sclerotic ends, took the fibula and the small K wire I placed, and then placed the monolateral fixator, the iliac crest and some cancellous bone graft, and applied the plaster. And I told family that this may go for, it may not unite, and then we might have to resort to something else. But this is a very young child, so I wanted to give a trial of this, and show the follow-ups, Meet.
Yes. So this was the follow-up on 15 days. This was a 2.5-month follow-up. And we can see that the osteotomy site has united well. And the ulna, the fibula graft that we had kept is also uniting.
Can you just go back to the first X-ray?
Go back, Meet.
Yeah, because there's the ulna at the distal end also seems to have grown, yeah, which is surprising.
Go back.
Go back to the even
Go
earlier.
back to the first X-ray.
There seems to be such a hypertrophic ulna here.
Yeah.
Go on.
Go back.
So
now come to your follow-up one.
Yeah. Now.
So this was the 3-month follow-up. This was the most recent follow-up that we've had. The radial osteotomy site has united well, and the fibula graft has also united.
So even the distal ulna seems
it has grown quite well actually. This is like because it was so thin earlier.
Yeah. So as it is said, no, once it gets under pressure or aligned, that starts going. So it
very quickly,
fortunately the fibula was taken up very well on both the ends. And child is currently at UK, and they sent me the videos today. So Meet, can you show that?
So this was a 3 months follow-up that we had, and to look at this was how the patient was prior to the surgery. We can see that he cannot pronate his left forearm well. And this is what we have achieved at 3 months. Flexion extension has been achieved.
So he's moving his thing at the shoulder, isn't he?
So pronation is not there, but I have just immobilized him in a supination because that's a functional position.
Left hand, yeah.
Yeah, and he's doing pronation from the shoulder.
Yeah.
But otherwise, cosmetically, and he looks pretty well.
Yeah. So I've done quite a few fibula grafts in my life, and somehow I have close to only around 50% good success on both sides. So, yeah. So I've sort of been a little more wary of doing it, but excellent result, no doubt.
So Bansi says, so why do people go for UK? But I think the post-infective bone loss experience is what we have
is much more,
yeah.
Okay, Maulin, I'm sorry I have to leave.
So thanks John for your presence, and just give a final comment to the fellows, and then we'll conclude.
No, I think this was a group of excellent cases with very good learning points. So I think forget you guys, we've benefited from it. So I'm sure you would have benefited from it. And so thanks, Maulin. As usual, these meetings are good, and always a lot of things to learn from it. So keep it going. That's all.
Thanks.
Right.
Yes,
okay.
Dr. Gupta ji, thanks for your time, and final comment before we wind up.
Thank you, Ne. I think these are very, very interesting cases, and very unusual cases, and very, very challenging. And I think at the end of the day, it's important to identify the pathology, and it's important that as far as possible, try to reconstruct the anatomy as far as possible. I think that's the overall message which I would wish to, conclude from this. But these are very, very challenging cases, and should be, should not be taken up by the people who are, especially the last case, I would have actually considered a single bone forearm. So very nicely done cases.
So thank you very much, Gupta ji, for your time, and thank you everyone for your time. Hope we'll meet soon. We have Brachial Plexus Journal Club next Thursday with Dr. Alain Gilbert participating from France. So that will be an interesting session too. Take care. Good night. And Sheenam and Meet, nicely presented cases. Thank you.
Thanks.
So I'll just end meeting. Take care. Yeah.